Well, welcome everyone to the talk by Dr. Nageshwar Reddy, Asian Institute of Gastroenterologists in Hyderabad, India. And this is on a series of seminars that we hope to have for the coming year. Hello, my name is Ram Sriram, and I am the President-elect of the Washington Academy of Sciences, and I will be your host today. Dr. Nageshwar Reddy is currently the chairman of Asian Institute of Gastroenterology in Hyderabad, India. He's also the past president of the World Endoscopic Organization. He's a very famous gastroenterologist, and if I talk about him, I'll be talking the whole hour about his achievements. But he has published more than 600 papers in various avenues, contributed chapters in 10 international textbooks, and is an editor of 3 GI endoscopic textbooks. He has got numerous awards and he has been recognized by most of the gastroenterology agencies around the world, including the World, I think, Master of World Gastroenterology Award from the World Gastroenterology Organization in 2014. He's a fellow of many organizations, including AAAS, I think a fellow of the Royal College of Physicians in Ireland, and is also he also received the Padma Bhushan Award from the Government of India, which is the third highest civilian award given out by the Indian government. So without much ado, I would like to welcome Dr. Nageshwar Reddy. And also, there will be a chat here. So if anyone, the way that we are going to have this talk is Dr. Nageshwar Reddy is going to make a presentation of about 30 to 40 minutes. And then we want to open up for Q&A. For Q&A, we would like you to put it in the chat so that Dr. Nageshwar Reddy can respond to your questions as we go. Okay, now, Dr. Nageshwar Reddy, please share your slides. Okay, good.
Yeah. At the outset, I'd like to thank the Washington Academy of Sciences for giving me this opportunity to talk on a problem that I think is turned our world upside down. A problem that has changed the medical scenes, changed the economic scenes, has created a huge social disruption all over the world, the COVID-19 crisis. And what I'm going to do over the next few minutes is to try and give the Indian perspective of what we look at it from here, because I'm sure all of you have gone through so much of news that comes in this area, but from India, it's a little different view that we look at. Our world has changed. Before the coronavirus, this is how the hospitals used to be in India, full of crowds everywhere. We couldn't, it used to be all packed. And now, after the COVID, you see everything is empty. The hospitals have COVID patients, but the general patients have come down remarkably. There are very few general patients that we're seeing because patients are afraid to come to the hospital, and also because there is this risk that they'll get COVID when they come in here. So we have this BC and ACs, what happened not only in the hospitals, but in the whole sphere of activities everywhere. So what I'm going to do is this. I'm going to give a brief outline of the current understanding of the SARS-CoV-2 virus, speak about how it spreads, what are the strategies taken to arrest the spread, what are the socioeconomic conditions that are responsible in managing this disease, how healthcare workers in India are coping with the stress, what are the current therapeutic strategies, and how specialists, especially gastroenterologists, are dealing. I'll talk a little bit of vaccine later because that's what's in news now, and what's going to be our future directions in this area. So this is a very crowded slide, so I'll just take a few minutes of each to tell you. And this is the world map of COVID, and you'll see that the dots everywhere. 191 countries all over the world had this problem. And you can see the density of dots vary in different countries. You can see the very high density in North America, a little less in Canada. South America is getting very dense too. Europe, especially the Western Europe, India at one stage was, and you can see Africa is very less represented, and also where it started from. In China, you see it's also at a very low rates right now. So this virus has affected the whole world, but in varying proportions. And there are many theories why this happened. We'll come to that a little later. But certainly all of us, wherever in the world you are, you've been affected with this virus. Now, this is an interesting statistics map that I just got from India. And you can see the Indian trend that there was this so-called first wave which occurred in August, September, October in India. And what we anticipated was a second wave to come in the later part of the year in December. And this hasn't happened. Again, I'll come to certain reasons why this hasn't happened later on. But you can see that right now, December 15th, that is today, we have just had about 25,000 cases with only 500 deaths, which means there's a downward trend. At the peak, India was having about 100,000 cases a day. So there's certainly something that has changed, and I'll come to that a little later again. And this is another interesting graph that I'd like to take you through. And this is what has happened in 4 or 5 countries where the pattern of manifestation or pattern of how it's actually manifesting is different in different seasons. For example, United States, you see the green line here, has undergone 2 or even the third wave now. You can see the first wave, the second wave, and then the third wave, and it's going up and up and up. Whereas some other countries are starting to see the second wave, especially in Europe. For example, in UK, France, and in Germany, the second wave is coming. But if you follow what happened in Brazil and what happened in India, see this line. This is the Indian line, which really peaked somewhere in September, October, and then started coming down. In November and December, it's going down. A similar thing is happening in Brazil. Now, what is different between all these countries? Actually, if you look at the paradox here, the Western countries and the economically rich countries are having this second or third wave, whereas countries which are not fully developed, the emerging economies are having a lower, or there's a drop in this incidence of COVID-19. This means that it's actually not just the treatment or the protection that's happening, but there's something innately different in this population which is resulting in this. And this, again, something that I'll touch on later, that we require to protect ourselves, but there's some other factors also which are effective in this happening. So certainly there are some countries seeing the second, third wave. There are others where it's coming down quite dramatically. Now, the entry of this virus has been very well studied in the last 1 year. We know everything about this virus. It enters through these ACE2 receptors, enters into predominantly the epithelial cells from the mouth, from the upper respiratory tract, from the lungs, goes inside the cell, and there it actually starts replicating. And again, paradoxically, the virus itself is not the cause of the problem in this case. It doesn't cause the disease. The virus interacts with the human immune system. And as the immune system is trying to destroy the virus, it causes collateral damage, and that is what causes the disease. Initially, the virus is attacked by the army that we have, the white cells. This army, if it's able to eliminate the virus, it's okay. We have an asymptomatic phase or a mild fever, everything goes off. But in the process, as the army is fighting this virus, there are a lot of bombs which are released. These are the cytokines which are released from the body. And these cytokines actually cause damage, not only to the virus, but also collateral damage to the body. And all the effects of the virus, the lung affections that you see, all this respiratory distress syndromes and all, and death is because of this cytokine release. And this became quite clear as we studied the virus, that it's not actually treating the virus or eliminating the virus, but actually treating this body response, an abnormal immune response, which we should treat to see that the disease is arrested and does not progress. So quite paradoxical from other infections that we see. Basically, how is it transmitted from person to person? And this is something, again, we changed our views in recent years. It was thought initially that this infection is transmitted by so-called droplet infection technique. That is, you have some person who coughs or who sneezes, the secretions fall on a surface, you touch the secretions, and then you touch your mouth or nose and so on, and then you get this infection. This was how this was thought to spread in the initial first 1 or 2 months that we had this virus. And everybody started hand hygiene and washing and so on. What we didn't realize was this was actually not the main mechanism. The main mechanism was actually something different. And this was actually a study which came as a letter in the New England Journal, which was not noticed much, but we showed clearly that this virus actually stays in the air for long periods of time, up to 3 to 6 hours. And if you have a closed room with air conditioning, it can stay for a long time. In an open air, it doesn't stay for so long. So this is the aerosol transmission. And it can stay on surfaces for several hours together. Now, what we now know is that predominant transmission is through aerosol method, that this virus comes into the air because somebody is sneezing or talking even loudly. If you talk very loudly, all this virus gets sprayed into the atmosphere. It stays there for 2 to 3 hours, especially in closed rooms, and then gets transmitted from one person to the other person. So this airborne transmission is much more important than droplet transmission. And what has this resulted in? This has resulted in a way to better prevent this infection. And one of the ways to prevent it is, of course, masking. And this is again the reason why this virus didn't actually become rampant in certain countries. For example, Taiwan, next to China, started masking very early and the virus didn't spread. They had very few cases. Similarly, South Korea, Hong Kong, Japan, where masks were started very, very early. In many countries, including India and United States, masks came very late. And even now, there's a lot of resistance about masks. But we clearly know that because this is an aerosol distribution of this virus, it's masks that are going to protect us. And this is, again, it took a gap of about 2 months to realize this knowledge. And that's the reason why rampant spread occurred before this. So when this virus actually enters into the body, there can be a variety of manifestations. Predominantly, it's the pulmonary related to the lung. So you get cough, you get infections in the lung, you get densities in the lung, and you develop ultimately a failure, lung failure, which is called the respiratory distress syndrome, acute respiratory distress syndrome. And that is ultimately the cause of death because the body is not getting enough oxygen. But some of these patients can have other manifestations. And again, we started realizing this. For example, you can get massive heart attacks. This is because the virus goes into the endothelial part of the blood vessels and causes thrombosis or obstruction to the vessel, causing a cardiac attack. Similarly, we have seen many young patients coming with paralysis because of blocks in the arteries supplying to the brain. So these are the other manifestations. What is interesting to me, because I'm a gastroenterologist, is that a significant percentage of these patients come with gastrointestinal symptoms. The reason why this happens is that the same receptors that are there in the lung is also present in the gastrointestinal system, that is the ACE2 receptors. And it's believed that this results in manifestations of the gastrointestinal systems and also manifestations in the liver. 15% of the patients and about 20% of liver patients are because, if you take the total number of patients who come to us with COVID, around 1/3 of them actually have some form of gastrointestinal symptoms. And some of them come only with gastro. There's no fever, there's no cough, they come only with gastrointestinal symptoms. That is 10%. So most often, the gastrointestinal symptom is form of diarrhea. I've had many patients who haven't had fever, haven't had cough, just come to the OPD saying that they've had diarrhea for some time. And when we test them with RT-PCR, we find that they're COVID positive. So this was the cause of diarrhea. They can have nausea, vomiting. The other very interesting symptoms some of them come with are anosmia or dysgeusia, that is loss of smell and loss of taste. This is very interesting because this can come even before the disease. I've had patients who come and tell me that, oh, the last 1 week I can't smell my food, I can't taste it. And 2 or 3 days later, they develop fever and the classic features of COVID. So this is also very important. 1/3 to 2/3 of the patient who have COVID, actually loss of smell and loss of taste for food is very important symptom. Now, a lot of COVID also, the SARS-CoV-2 virus is excreted in the feces. And this is important because it is thought that some of the spread could occur because of this. It goes into the feces, can occur through oral route. Transmission can occur because it gets shed into the stool, and you can actually find a pathway of how this is going through different communities based upon the presence of this virus in the water specimens of different communities. And this has been done in several parts of the world. So for us, of course, it becomes important because it's got an epidemiological significance to trace how the virus actually started. But another very important thing is, this is a work which came from my friends in Hong Kong, where they showed, I don't want to go, this is a very complicated slide, just to show you that in patients who have COVID-19 have a dramatically different microbiome in their intestines compared to normal people. Now, it is believed that this disease manifestation can be mild, moderate, or severe, not based upon the virus itself, but based upon the body's immune reaction. And the predominant immune reaction is coming from the gut bacteria. So you have millions of bacteria in the intestine. How these bacteria react with this SARS-CoV-2 virus determines how severe your disease becomes. And this is, again, very interesting because there are some very early studies to suggest that if you can manipulate the gut bacteria by giving oral bacteria and things like that, you can actually alter this disease. And there are some suggestions that even FMT, that is fecal microbiome transplantations, can actually have a part in curing or decreasing the severity of disease. Very interesting hypothesis. The liver is also damaged. You can get liver damage directly because of the virus, but it can also occur because of decreased blood supply, because of cytokines, and many of the drugs that we use for treating this disease have actually caused injury to the drugs, to cause injury to the liver. And about 30% of the patients can actually have liver-related problems. How does it affect our practices? And this is a survey that we published in Gastroenterology, which is the official journal of American Society of Gastroenterology. And we, from the World Endoscopy Organization, looked at endoscopy centers all over the world. We actually sent questionnaires to over 250 centers, United States, South America, and various parts of the state to see how their practice has changed with COVID. And you'll see this, that in all these centers where the endoscopy rates with 100% has dropped to 10%, 20%, and so on. That means there's been a dramatic drop in the number of endoscopies that were done during this period. This is because the patients are not coming, and also because we are now telling them not to come for simple problems. For example, screening colonoscopy is not being done during this period because we know this is not so important. This can wait till this is over. Similarly, elective endoscopy for various reasons, dyspepsia, for example, we're not doing because we ask the patient to come back later. But also this had an effect on the patient. Some of the patients, for example, with GI bleed, who require emergency endoscopy, are not coming in time to the hospitals and are dying because of this. So this has created a problem. So right now, all emergency endoscopies are being done with precautions. Elective endoscopies have come down dramatically all over the world. And this has changed the pattern of practice. And also how we look at these patients has changed now. Not only in the endoscopy rooms, we're all covered up completely. We never used to do this earlier on. Now it's all shields, masks, aprons, and so on. And also the patients, when they're endoscope, have glass coverings on them, plastic coverings on them. This is to protect both the doctor and the staff around from transmitting the infection. And there's some very interesting statistics I'd like to share with you here, that we have two regions in a hospital, the COVID area and the non-COVID area. And we looked at the infection rates in both these group of areas, that is infection for doctors and the hospital workers. And we found that out of the 4,000 workers we have totally, we had about 200 of them had actually COVID, and 200 of them actually had antibodies against COVID, indicating they were actually infected but didn't show any symptoms at all. But when we looked carefully at the statistics of who were developing this infection, we found that more people in the non-COVID area were developing infections compared to those workers working in the COVID area. And the reason is simple. The reason is all the doctors and healthcare workers working in the COVID area were protecting themselves very well with masks, with gloves, and so on. Whereas those in the non-COVID area were make more casual and had a more chance of infection. This is a very important message that we actually send forth to our doctor colleagues, that if you're protecting yourself properly, the chance of COVID coming to you would be very less compared to somebody who's more careless. Of course, our hospital practices have changed. There's been a lot of anxiety among both the doctors and the healthcare workers. I think this has been reported all over the world. Burnout syndromes have increased. Many of the doctors are actually retiring. And just today, there was a news from US that over 160 healthcare workers have done a mass resignation because of the stress involved in treating this. A hospital has got sanitation systems in which patients enter to come in. They're seated far off now. They don't get, they're separated out. So physical distancing becomes very important nowadays. So what happened in India was that the first cases were reported very early January, but ignored. Again, February, there were a few cases. These were actually students who came back from China. But the government took cognizance only somewhere in middle of March. And the first lockdown came in middle of March. They continued this lockdown in some form of fashion, either in a decreased form and so on. So there is lockdown 1, lockdown 2, 3, 4, and lockdown 5, which was ultimately in June in containment areas. And finally, in June 8th, the first unlocking occurred, partial unlocking, so that people could go out to the markets, could do some shopping and so on. So these 4 months were really bad for India in terms of economy, in terms of psyche of the people, because all were confined to the houses and we didn't know about this virus much. We were looking at high mortality rates that were reported from various countries all over the world and so on. So this was a really troublesome period for all of us. Unlocking occurred. But lockdown had some benefits. One was that we are not so prepared for this epidemic. Like some of the Southeast Asian countries who had the first SARS-1, they were very prepared. Hong Kong, Taiwan, China, and so on. So they already had some capacity building. We didn't have it. So during this period, lockdown period, the 4 months, the Indian hospitals had capacity building. They put in more ICUs. We got more ventilators. We understood the pattern of this disease. But more important is the protective equipment that the doctors, healthcare workers required came in. And this is where India did very well. Most of our garment industries were converted into industries to produce this. So that paradoxically, we never had shortage of masks or protective gears, gowns and so on. Compared to, say, what happened in the United States, where you had mask problem, masks and all, we never had that. We had abundance of this right from the beginning. Of course, in these 4 months, we started to understand the disease, that this was a respiratory virus, but was spreading to aerosol. So we knew that masks became very important. We knew that the virus itself was not important, but the immune system from the body fighting against the virus became more important. That's how we should control it. We actually controlled the cases coming in, so the mortality surge came down. So these were all the benefits of lockdown. There were, of course, unfortunately, the downside. The most important downside is the economic impact that it had on India. In fact, India was one of the countries which has the largest economic downfall because of COVID. We had great problems because most of our labor was in unorganized section, and they had to go back. After this was COVID, lockdown was declared. There were a lot of problems at that. But more important than this was stigmatization of the disease. And this is something which was, I think, became a big problem for us. The stigmatization that somebody has COVID is very dangerous, don't visit him and so on. So patients were abandoned. Even nobody came to claim the dead bodies. They were actually buried by the government sometimes. There were situations where the whole flats in one particular area were completely locked down because one person was found to be COVID positive. It was the beginning phase when the stigmatization occurred. This was very, very problematic for us. In fact, I've had many patients at that stage who would come to me and say, I would see them for some other reason. I say, okay, you have unfortunately cancer of the stomach. The patient would tell me, oh, thank you, doctor. I hope it's not COVID. So they would even think that COVID was more serious than cancer. This was the stigmatization that occurred. And of course, there's other problem that occurred is as lockdown came off, there's a post-lockdown freedom, and this is something that is affecting, I think, all the countries. There's unrestricted freedom. People went around markets without masks. Everybody was, these are wine shops they were going to, no masks. So this became a major problem, and this resulted in a small surge that occurred after this because of this. So our lockdown was removed in June, and then in September, October, we started to see another wave coming in because of this unrestricted freedom. But we soon realized that this was a cause, and again, now protection has come in. Another remarkable thing that happened in India was an example here. This is Dharavi slums in Mumbai. This is Asia's largest slum. Millions of people live at very close proximity in these slums with hygiene conditions which are, of course, not very good. And it was expected that once COVID comes in here, it's going to spread like wildfire. That will be extremely difficult to control, that millions of people would die. But something strange happened here. One most important thing, the government got very active. They did very aggressive, because a small confined area, they could do very aggressive contact tracing, isolation, and so on. And the few patients who were positive were quickly taken out. Also, these people seem to have increased innate immunity. So finally, up to now, over the last 8 months, a few hundred people only have developed COVID here, which is very strange. And they're going now about their own businesses because people don't seem to be affected by this. Government also tried other things. For example, this is what we followed from what happened in China, in South Korea, and so on, that the phone apps came in, and in the Indian government, it's called Arogya Setu, where those who are positive were loaded onto this, so that whenever you're going around with your smartphone, if you are near somebody who has COVID-19, then your phone lights up and you know that you're near somebody. Of course, this didn't take off as well as expected to, but I think it's a good attempt that the government made. Now, coming to certain aspects of the treatment, I don't want to talk too much on this, except to say that we, of course, know that hydroxychloroquine is off, is no longer shown to be effective. The other drugs like remdesivir, dexamethasone, and this is a drug that you would like to talk a little on, and this is important for India, because what happened is remdesivir, which came in United States, was extremely expensive. 3 Indian pharmaceuticals quickly made this at 1/10 the cost, 1/10 the cost of the drug which is available in United States. And because this was cheap, it became widely used. And we realized that if you use remdesivir in the first 5 days of infection, then you can control this infection very well. Unfortunately, most of the studies that came out in West from United States, from UK and so on, were using remdesivir at the last stage because of the expense involved, availability and so on. And then if you use this in the second week, it's not going to be effective. So therefore, WHO declared that it may not be effective, and people started following it. This is not true. We have had experience of treating 3,000 inpatients with COVID-19 in a hospital, and we're going to, of course, publish this shortly. We have shown that remdesivir used early, within the first 5 days, is quite dramatically effective. Of course, dexamethasone is also being effective, and we have actually made out a chart based upon our experience of 3,000 patients. What we find is that if we start using remdesivir within 5 days, it's effective. There are other oral antivirals that are also effective, available in India. Efficacy is not so well evaluated. Favipiravir is one example, used extensively in various parts of the country. It's oral. It's not, again, very expensive, so it's prescribed quite a lot. Monoclonal antibodies are still not available, but we're using a lot of convalescent plasma. And now, again, in our experience, if it is used, if you look at the antibody levels in convalescent plasma of somebody is required, if you demonstrate high antibody levels, and if we use this in the first week, we found this to be effective. Steroids, of course, are reserved for the second week, and this is very important. This is, again, another mistake that's made all over the world, starting steroids immediately after detecting the infection. Steroids are only to fight the immune system after the virus and immune system have collided. So this happens in the second week. And therefore, if you use steroids in the second week, you actually protect the patient from immunological turmoil that occurs. And therefore, dexamethasone is commonly used at 4 milligrams. The other drugs that have been used to decrease the immunological fights are tocilizumab. This is little toxic, produces immunosuppression. And to decrease fibrosis, used colchicine. But more importantly, just 2 days back, there was this article in New England Journal using baricitinib, which is a JAK1, JAK2 inhibitor, which actually decreases inflammation. Doesn't suppress immunity like steroid, but just decrease inflammation. So this may become an ideal drug. And my belief is, and this has been shown in the study in New England Journal, that if you combine remdesivir in the first week, followed by using baricitinib in the second week, then your mortality rates will come down dramatically, and most of the patients with COVID-19 can be saved. And I think this is going to become the standard of care in future. One of the things that we started learning also is about ventilation. You should not ventilate these patients too. We try and decrease ventilation because ventilation produces barotrauma and so on. We give a lot of nasal oxygen, and we give this now through a high-flow nasal catheter up to 40 liters per minute without ventilation. And we realized again that if we don't ventilate these patients but give very high-flow nasal oxygen, then you can protect a lot of them. They recover from this. The problem also is we're starting to realize now there's what is called the long-haul COVID or the long COVID, which some of these patients are recovering from COVID. They become all right, but over the period of time develop other symptoms which are classic of autoimmune disease. They develop joint pains, they're developing respiratory problems, they develop a chronic respiratory insufficiency, they develop hypertension and so on. All these are called the long-haul COVID, and these long-term results are occurring because the body is producing a lot of autoimmune antibodies. And again, this week we have a non-peer-reviewed article from very famous Japanese immunologist who showed that body is producing thousands of autoantibodies in patients who have COVID, and some of these patients will go on to have autoimmune diseases because of this. One very intriguing problem was that we have very low mortality in India. In fact, if you look at mortality, both case fatality and true mortality in India, it's less than half of United States. United States is having mortality rates of 3 to 3.5%. In India, it's 1 to 1.5%. In our own experience, it's been 0.5%. Why is the mortality so low in India? There have been several explanations, including the lower age group, population in the villages spread out, less comorbid condition and all. But I feel this could be much more innate to something else. For example, innate immunity, which is different. And there's some very early work coming in. Again, this is under publication, so I can't quote it completely, but there's very early work suggesting that Indians have a protection because of decreased entry of the virus, because of certain mutations that are occurring, and also the HLA components in Indians may be a little different, and therefore the immune system is not reacting to the COVID-19 virus as it should in normal population. So there are many factors. It's very interesting that over the next few months, we'll get answers for many of this, and probably that will benefit others. And we also have a large number of asymptomatic carriers. These are problem patients because they are the ones who transmit to others they themselves don't have. So asymptomatic carriers is one of the problems that we have. And we also realized very early on, and this is something that we follow very strictly now, masking is becoming compulsory. I know there is resistance to masking among certain populations, but I think I'm a very strong believer that masking can actually prevent this to a large, maybe as good as vaccination. In fact, there are some studies which have done modeling studies which have shown that if you can, all the population has masks, everybody is using masks, then it's equivalent to 90% lockdown. And what masking does is not only decreases the transmission of the virus, but decreases the extent of transmission. So even if you develop an infection, if you have a mask on, the amount of infection coming in is less, so you may have a very mild infection. In fact, it's some sort of immunity you develop. So I think masking, extremely important. And this is something that I think in India we realized it started very aggressively now. The second is physical distancing. I think the wrong term of social distancing has been used for this. We should not socially distance ourselves. We should be in communication. Human beings are social animals. We can't socially distance ourselves. But physical distancing, it's been shown on average 6 feet is where this virus transmits. Maybe 9 feet is better. But when you're sitting down in meetings or when you're watching something with people together, a distance of at least 6 feet is important for this virus not traveling. And of course, hand washing has always been emphasized. There's a variety of masks. Again, I said India has been fortunate that these so-called N95 masks have been produced in large numbers. They're very freely available. They're very cheap now in India. And so this is one of the problems that we didn't have. But I think it's important to realize that masks are still most important, and this should be used extensively. There are many uncertainties with this virus. For example, whom should we test? Should we test the whole population and try and do contact tracing, isolation? Should we only test those who are symptomatic? When should we vaccinate? And there's other problems of vaccination come to. The treatment has been now to a certain extent regularized, but many new antivirals are coming. And is there a true prophylaxis against this virus? This is something that where the questions about. But certain things have changed, and certain things have changed forever for us. First of all, I think education, medical education has changed. It's going to be tele-education. We have a lot of the seminars every day. We have many seminars all over the world. This is good in a way, bad in a way, because again, it's always good to be among the audience when you're talking, see their reaction, discuss with them. But we reach much larger audience with this tele-education. And also telemedicine is becoming more and more used now. In fact, before COVID, telemedicine was, it was illegal to prescribe medicines in India for telemedicine. But now it's been legalized, so telemedicine is something that we're using a lot, which I think we're going to use in future. It's not going to go off immediately. So what has been normal earlier is no longer normal. We are going to achieve a new normal probably after the vaccine is given almost to 70% of the population. But that's going to take some time now. So till that time, a new normal is going to come, and it's going to take, in my opinion, several months, maybe till end of next year. Let me discuss a little about the vaccines, the last few minutes on the vaccines, because this has become the big news now. United States, I think the last 1 week, the news has just been on these vaccines. There are several types of vaccines. Over 250 candidate vaccines came in in the initial part. About 50 of them went into clinical use. Around 60, 70 in phase 1, phase 2 trials. And 7 have cleared the phase 3 trials. Out of the 7, one has been approved. The Pfizer vaccine has been approved in UK first, and then United States, Canada, in 7 countries, including Bahrain, Saudi Arabia, Singapore. And next week, probably the Moderna virus, which also is mRNA virus, is going to be approved. The vaccines that are being made in India, and I'd like to mention here that India was originally thought to be the vaccine capital of the world because there are several companies making large amount of vaccine, which are then given to the rest of the world. But these vaccines are mainly adenovector vaccine or attenuated virus vaccine. There are 3 vaccines in India presently which are being in phase 3, going into phase 3. One is the Bharat Biotech vaccine, which is an attenuated virus, which has been made by Indian scientists. And we have also actually participated in the vaccine trial. And we have seen that this vaccine is quite effective, 70% protection. It's in phase 3 now. The other vaccine is the adenovector vaccine, which is the Oxford vaccine, which is now being produced by a company in Pune, Serum Institute, in large numbers. They are the main people who are going to produce this. This is a chimpanzee adenovector, which is inactivated, on which the spike protein is there. And this vaccine is again going into phase 3 and will probably be available by mid-January in India. There's another vaccine called the Sputnik vaccine. The Sputnik vaccine came from Russia. It's an adenovector vaccine. And 2 labs in Hyderabad are actually taking up this vaccine. They're producing the vaccine going to phase 3. And again, soon we'll get approval for these vaccines. But these are the vaccines. The problem of this vaccine is going to be how to deliver this vaccine to a large population. Even in a country like United States or UK, this is a problem that's been discussed over and over. You deliver, because it's believed that you have to actually vaccinate at least 70% of the population to develop immunity to protect this epidemic from going on. And to deliver to 70% of the population in India would mean almost 1 billion people. How do you get this vaccine? Especially the mRNA vaccine, which is expensive, has to be stored in -70 and so on. But the mRNA vaccine, I think this week's New England Journal very clearly showed the positive results of the Pfizer vaccine, which is, I think, the first mRNA platform vaccine. This is the mRNA is put into lipids. It goes into the body, injected into the body, where using the body's ribosome, it produces spike protein of the virus. The spike protein is the one which actually causes the virus to enter into the body. And if you have antibodies against the spike protein, then the virus cannot enter into the body. So this induces a lot of antibodies against the spike protein with a very high efficacy rates. And you can see that a 95% efficacy rates have been demonstrated in the study using 30,000 volunteers who were given either placebo or this vaccine. And you can see that 162 in the placebo developed the infection, whereas only 8 in the group which had the vaccine, and most of these were very, very, very mild infection. Moderna has got similar impressive results, and that is going to be coming in. So I think these mRNA virus vaccines are going to be very effective. And another thing that this virus has taught us, the corona has taught us a lesson, is that science can be very dominant. That if you have good science, you can actually produce much effective results. Just imagine that a vaccine which takes normally 5 or 6 years to develop has been compressed in 11 months. The whole vaccine science has dramatically moved forward, so that we are now so good at it that maybe the next vaccine may come even in 6 months. So this is, I think, one of the benefits of the lessons that corona has taught us. But what's going to happen in future? I think beyond COVID-19 is something we should look for, because what we define as the new normal is going to be different from what was old normal. We're going to look different, very, very different. I think this COVID-19 has taught the world many lessons. It's taught the world that we are connected together. It has taught the world that what happens in one part of the world can very rapidly get transmitted to other part. Inequalities are going to be a problem unless, for example, the whole population becomes immune. All population of the world, this pandemic cannot be stopped. So it has showed us that inequalities are not good for this world. It has also showed us that what cooperation and science can do. A fantastic scientific cooperation has resulted in this vaccine coming up, and I think these are some very positive benefits that has come up. So when people tell me that, oh, corona has produced so much of problems, COVID-19 has caused depression in the world, economic turmoil and all, I tell them, look at the positive side. It's taught us so many lessons that science can conquer so many things that we thought it couldn't. I think this is a very positive message. So the new normal has changed, as I said. This was many years back, before we had this COVID infection, when somebody was wearing a mask, we usually thought, what's abnormal with this person? He probably has a respiratory infection or something. But now if somebody is not wearing a mask, we say this is very abnormal. This person, something is wrong. So I think our whole attitude has changed, and this is something which is not going to come back very easily. And finally, I think I'd conclude to say that what COVID has taught us, that no man is an island entire of itself. Every man is a piece of continent, a part of the main, and that this interconnectivity becomes very important. And hopefully this has started lessons that not only should we be interconnected, work together, but also I think we should respect nature, that any interference with the nature can result in disastrous consequence like this. Thank you very much for this attention.
You have a number of questions on the chat. Let me start with asking you a question. You have mentioned in one of the slides about various masks. Is any one of those masks better than the other mask? For example, is a surgical mask better than a cloth one?
There are definite differences in the masks. For example, the mask, which is N95, is the most effective because it filters the virus completely. But what happens is that it's not easily available because of the cost, although in India it's becoming easily available. So this is not easily available, the standard surgical mask, which is a 3-layered mask, the blue mask which you see, can be used. This gives 80% protection compared to almost 98% protection than 95. The cloth masks also give about between 75 to 80% protection. The advantage of the cloth mask, of course, you can use it and reuse it, and you wash it and reuse it, and of course you can have designer cloth masks that are coming in now. But all masks are not same, but any mask will definitely help to some extent. So I would suggest that till we get rid of this virus, whatever masks that you have access to should be used, at least in crowded areas, or if you're going indoor with other people are there. But if you are in the house by yourself or with the family who is not exposed, then there's no need of wearing a mask.
You mentioned the mortality rate in India is 1.5%, but in your hospital, it's only 0.5%. Why is it so low in your hospital?
Yeah, so in India, generally the mortality is very low because of a variety of reasons, including the innate immunity, HLA, and so on, which are now actually going to come out soon in publications. But in our hospital, I think this is what we showed, that if you get these patients in the right time, they come to us the first week, and if you have a regimen of treatment which is very standardized, like using very early remdesivir, especially for those above the age of 60 years, those who have comorbid conditions like diabetes, hypertension, and so on, and those who are immunosuppressed, we immediately start them on remdesivir, especially if they're symptomatic, and follow it up with another drug for immunological suppression in the second week. So if we follow this protocol, then we find that the mortality rates are extremely low. But what happens is most of the patients are being seen in the second or third week in the community, and they're being given steroids at that stage when the virus is multiplying. Then you get a higher mortality rate. Now, why is the mortality rate much higher in the Western world, especially United States and Europe? There are several factors again. One of the factors may be contributing predominantly is the obesity. We find that obesity is a very important comorbid condition that increases the mortality. And of course, the temperature conditions there is another thing. And steroids are being started very early. That's another problem that's occurring there. And plus, of course, I think there's still some mask resistance. Many people are still not, for some reason, at least in the US, not wearing masks, whatever the reason is. So that I think all these things together are resulting in much higher rates of more severe infection that you're seeing.
Thank you. You also mentioned the virus entry through the ACE2 protein. But I also remember you did some work on TMPRSS2, and if you had indicated that a mutation of that has some implications on the virus entry. Can you tell us a little more about that?
Yeah, I think that plays a very important role. I didn't go into the scientific detail because I thought there may be a lot of non-doctors here. But this is something very important, that when the virus actually enters through the ACE2 receptors in the body, it can't enter by itself. The body has an enzyme called TMPRSS2, which actually helps the virus to enter into the body. So it's a body straighter. This enzyme helps the virus to enter into the body. Now, in 50% of the Indians, we find that this enzyme, TMP-RSS2, is mutated. There's a mutation for some reason which has occurred. And because of this mutation, this enzyme cannot help the virus to get inside the body. So that's how we are protected, fortunately. This mutation has occurred many years ago, maybe centuries back in Indians this occurred. We don't know the reason, but this protects us. So this is something which now we are starting to learn. In fact, we can actually now do a survey and say which patients are likely to become serious, which patients don't require vaccine, just based on TMP-RSS2 mutations.
Thank you. Thank you, Dr. Nageshwar Reddy. Again, as I mentioned before, you have a lot of questions on the chat. T, as a question about contact tracing, can we know your thoughts on that? So in terms of the trust, trust problems.
Contact tracing in India use local community or people from outside the country. So contact tracing in India was mostly using local community health workers. There's a strong network of community health workers in India. And these community health workers, in fact, took the risks to do this contact tracing. This contact tracing was, for example, very strong in certain areas like the Dharavi slums that I showed you earlier. There are, of course, also informations that are being passed on by non-community health workers from neighbors in certain areas that there's some patient here developing and so on. But predominantly, it was community health workers.
Thank you, Dr. Nageshwar Reddy. Sudarshan has a question about why it took so long for people to understand the airborne transmittal of the disease.
This is a very interesting and very important question. That why did it take us such a long time to realize this was more airborne rather than the hands causing the infection? I think part of it was from WHO. From WHO, in fact, came out earlier on, very categorically saying that this is not airborne. Masks will not help. It's mainly droplet infection, so you touch it, you get it. So this was the first 2 months, a very strong message which came from WHO. It may be partly because nobody understood this virus at that point of time, but I think it was also partly because they thought it was different from SARS-1, which was predominantly airborne. The other reason was this virus is being transmitted from asymptomatic individuals to others. If it was from symptomatic, then we would have known definitely it's airborne. But because asymptomatic, people thought it was a droplet infection. So because of all these confusions, took us 2 to 3 months. But what happened in Hong Kong, Taiwan, and in most parts of China, in fact, I've had occasions to discuss with many of the doctors there. They didn't believe WHO. They went about and saying that we had SARS-1 earlier, and this is how it was transmitted, so let us take it as that. In fact, Taiwan was the first to ensure masks. They put a statement out against WHO at that point of time, saying that masks should be used. It should not be, as WHO has recommended, it should not be discarded. They should be used. So this happened. And United States, again, was much, much later. And even now, I think United States masks are not taken seriously. For some reason, after 3-4 months, only masks came into US recognition.
Thank you, Dr. Nageshwar Reddy. Annapurna Sriram has a question. Can the fiber vaccine be given to people with autoimmune diseases?
Yeah, so this is another interesting concept. It has been shown that Pfizer vaccine can cause allergic reactions and 2 anaphylactic reactions in UK. But so UK recommendation is that those with allergic reactions have to be careful about taking this vaccine. But this has not been the recommendation in the United States for Pfizer vaccine. It has also been shown that this can be given safely in autoimmune conditions, but the population of patients who actually received this vaccine with autoimmune disease are not large. So we still don't have the final data. But I would say that this might protect also, because what is happening in COVID is when the COVID enters into the body, it starts producing antibodies. Many of these antibodies are autoimmune antibodies. So if we can prevent COVID completely, you may decrease autoimmune antibodies. So I would think that indirectly, that even in autoimmune conditions where patients have autoimmune disease, you could use this Pfizer vaccine safely. Although, as I said, we don't have a large amount of data to say conclusively.
Okay. Thank you again. Before we go to the next question, there are a couple of other things on the mask.
This is interesting regarding morning walk.
Yeah, that's the one I was coming to. Morning walks.
I think this is important. I think.
Can you repeat the question for everyone?
Yeah, the question is, as you said, aerosols remain in air for hours. Do we need to wear masks during morning walk too? So what you do, we are thinking that you're going to do this morning walk outdoors. If you do your morning walk outdoors, the chance of aerosol infection is very low, which has been shown that because of wind, because of sun and other factors, the virus doesn't stay very long at all outdoors. It's very short period of time. So when you're doing a morning walk outdoors, there's no need of wearing mask. The reason this is important is that if you're wearing a mask, especially a tight N95 mask, there can be problems in terms of breathing, and we have had some incidences where the patients actually developed carbon dioxide intoxication because of this. So if you're having a walk outside in open air, which is not too crowded, for example, in a park, then I would suggest that you need not wear a mask. But if you're doing in a gym situation, a lot of people inside, then I would still recommend that we should use masks. This is very important.
Yeah, and also in terms of Dr. Rajesh is asking about GI endoscopy. So can you answer in terms of how?
So I think GI endoscopy, Rajesh, is very specific. So just to be specific, we have changed our protocols completely. Every patient now, of course, the first is a dress protocol. Every endoscopist, healthcare workers is protected with masks, with goggles, with a face shield, with gowns and double gloves. Everybody is protected. We also are now scheduling the patients in such a way that they're not crowded when they're waiting for the procedures, so they're separated. Any suspected patients or many patients in high incidence area, we are also doing a pre-endoscopy testing. The rapid tests are not now available. Within half an hour, we know, although the sensitivity of rapid test is only 60%, within half an hour, we'll know whether the patient is positive or not. So we are doing that for patients who have a high-risk procedure, prolonged procedure taking more than half an hour, we do a routine standard PCR test for COVID before we take them up for this procedure. So endoscopy has changed a lot during this period because of transmission, especially because the Italian endoscopy is where we started seeing first lot of people developing infections, the Italians, and then all these protocols came in.
Yeah, and also, in fact, going back to the mask, all is very concerned about the Indian farmers. Sees a lot of photographs of Indian farmers in large gatherings without wearing any masks. Do you have any thoughts on that?
Well, you're absolutely right. This is worrying us too. In general, if you look at masks in India, the use, you can divide it into North and South. In South India, a lot of people are using masks. It's more, people are more disciplined. In northern part of India, especially in Punjab, Delhi, a little bit mask resistance is there, especially among the farmers who are actually, this is a strike by the farmers against certain laws the government has passed. So they want to strike against everything against the government. So part of it is not to wear masks. We're worried our COVID has been coming down with this farmer strike without masks. We are sort of worried that we may have a small second wave coming next month. So you are absolutely right. But the problem is you can't force people. It's not mandatory. There's no law. So that's the biggest problem.
And thank you again. Ravi Sharma wants to know the period after the vaccination where one would develop antibodies. He also would like to know which of the comorbidities are important, are in terms of the priority of the comorbidities. For example, diabetes, cardiovascular events, or obesity. Which one is more important?
So coming to the first question regarding protection, again, we have done a lot of work with vaccine in our institute. And what we found is that if we use the standard adenovector vaccine or the attenuated vaccine, the antibodies come 15 days after the second dose. So you take the first dose, after 21 days, the second dose, the protection comes after 15 days. So after 36 days, you're protected. But with the Pfizer vaccine, it has been shown that you're protected partly by about 12 days after the first dose itself. So Pfizer vaccine has to be given first dose, second dose after 21 days. The protection is almost 95%, 7 days after the second dose. But in 57% of the people, there's been protection even after 12 days for the first dose. So this is good news for those who are taking Pfizer vaccine. Within 12 days after the first dose, 2/3 are already protected, and 95% get protected 7 days after the second dose.
But how long will it last?
This is a $1 million question that has not been answered. In fact, maybe part of this also should be taken up regarding the immunity that develops is partly because of antibodies and partly because of T cell memory. So body has got two types of cells protecting: the B cell, which produces the antibodies, and the T cell, which is actually cellular immunity. We know that these antibodies last for 3 to 6 months and then start coming down. But it's believed that long-term protection is occurring because of T cells, and it's also believed that this vaccine is stimulating the T cells. So hopefully it will for a long period. But people are saying, what about flu vaccine? You take it every year. No, will it be like this? This is different. The flu vaccine we take every year because the flu virus is mutating against very rapidly. Now, coronavirus also is mutating. And this recently in UK, last 2 days back, a very severe mutation occurred, making it more virulent. But fortunately, this mutation is not affecting the immunity. There is no mutation in the immunological part of the spike protein. And therefore, if this continues like this, then what will happen is if you're protected, when you take 1 dose of vaccine, the virus does not mutate, then probably we'll have much longer term protection. Even if you develop milder infections, that will keep adding as a booster. So my belief is that although this is not proved, we don't have data, our protection with this vaccine will be much longer than with the flu vaccine. Now, regarding the
go ahead. Thank you.
Regarding the comorbidity, obesity is the worst of the lot. People, we have found that those who are obese are the ones who are having the maximum morbidity, followed by diabetes. Another thing is, many of the people who develop this, the diabetes goes out of control. And unfortunately, steroids are used for the disease. Again, diabetes goes out of control. So diabetes is a vicious cycle with this virus. Cardiovascular disease, like for somebody who's having, say, a previous heart attack, that doesn't increase the problem. Hypertensives have a little additional problem. So of all the problems, obesity and diabetes are the ones which are going to cause more problems.
Okay, thank you. And then there's a question about food and nutrition. Do they have any effect on the...
and again, because before going to that, I think what T has pointed out regarding the restaurants is quite good. The aerosol degrades in sunshine, but actually in a restaurant, closed restaurant, when you're eating, when you're not covered, the chance of this aerosol locally being delivered to you from a more distant place is there. So restaurants and pubs are danger places, at least till we get vaccinated.
Okay, so do you have any comments on the nutrition and food?
Yeah, no, I think
impacts on the
nutrition. Yeah, nutrition, of course, again, very difficult to prove. It's been shown that malnutrition. There's been one study, especially in this virus in malnutrition individuals, showing that it has more problems, especially in those who have cancer, cachexia, and so on. It causes a lot of issues, and death rates are extremely high in this group of people. There's been some immunostimulants suggested in diet. Again, there's no clear-cut scientific evidence, although there's no harm in taking, for example, zinc or things like that to increase your so-called immunity. But again, there's not much studies which have actually shown it in form of a randomized controlled trial. Yeah. Mala asks, what is the pre-symptomatic, asymptomatic? Actually, it's very difficult to differentiate between pre-symptomatic and asymptomatic. Now, pre-symptomatic individuals are those who are in the incubation period. That is, they have the virus. After developing the virus, they usually take 5 to 6 days by the time they become symptomatic. So this 5 to 6 days is called the pre-symptomatic period. Whereas asymptomatic people are those who have the virus for even 14 days but never have any symptoms at all. So in the first 5 days, it's difficult to differentiate between pre-symptomatic and asymptomatic individuals. But it's believed that the transmission from pre-symptomatic is higher than with asymptomatic individuals, because asymptomatic individuals usually have a very low dose of virus in them. And when they transmit it, it's either very mild or doesn't get transmitted. Whereas pre-symptomatic individuals can have a very high dose of virus in their throat, and that can transmit it very high.
So thank you again for your excellent responses. We have about 5 minutes or so, and we hope you can address some of the questions on the chat.
Yeah. So we have Anand Bodapati talks about long hauler syndrome, like brain fog. Now, brain fog is one. The long haulers are going to be a problem. I think one of the problems we have conquered, to my mind, we are at the end of the beginning of COVID virus. We have conquered this virus with the vaccine coming in, such effective vaccine. I believe that at least in the Western world, by end of 2021, we'll be off this virus. And in US, for example, I think NIH director Francis Collins just yesterday gave a interview. I saw he said that by July, they'll have everybody vaccinated in US and Canada also probably much earlier. You'll have everybody vaccinated. So this virus is going to disappear by next fall. So that is going to be the end of the beginning. But I think the problem this virus is going to leave to us is a long hauler. That some of the people who have had a serious infection are going to have many autoantibodies. So we're going to get more cardiac incidences. We're going to get more asthmas. We're going to get more arthritis. We're probably going to have many more of these newer syndromes that are going to come in. Hopefully, for a period of time, science will help us to conquer these also.
So you want to look at quickly any other questions there?
Paul asked us about, do hospital workers have adequate PPEs, N95 masks? Yes, Paul. In India now, as I said, there's a huge production of this N95 and PPEs, and all the hospital workers have adequate supplies. There's no problem at all. In fact, sometimes we're changing an N95 mask twice or thrice a day also. It's quite available. Dr. Sanjeev Taplikar from Bidar asked that they have seen more lung damage. Are we getting a second wave? I think, Sanjeev, we will get a second wave if we behave like what is happening in Delhi when they're going around without the masks and the farmers' agitation. But fortunately, as I can see it from where you're coming from in South India, it is much less. Everybody is having masks, and also it's unlikely that we'll get a big second wave in January, although people felt that because all the Indian festivals like Diwali and all came in November, we may have a second wave in December. Didn't happen. In January, I feel that in North India, we may have a small second wave, which will calm down. But I think the vaccine, of course, is going to come in now. What are the precautions for IBD patients? Dr. Tanmay Saha asked. Of course, this again is very medical question. I won't go into the details, but certainly patients with inflammatory bowel disease should not take high dose of steroids. It has been shown very clearly that if you take high dose of steroids, more than 20 milligrams of prednisolone, your disease becomes much more serious. That should be avoided. They can take other agents, but not steroids. And then Dr. Sudarshan says...
the Baldwins have a question. They would like to know if remdesivir is available easily.
Yeah, Baldwin, this is again very important point that you raised. Remdesivir is easily available in India, but to take remdesivir, you have to go to the hospital. You can't take it as an outpatient, or you can't take it home. The reason why government put this law was remdesivir is very safe. You can actually take it home. There's no reactions. The reason why this law came into effect was they wanted to actually control the use to know how many people receive remdesivir, what is the effect, and so on. That's why this law came in India. You can take it only in the hospital. You can't take it as an outpatient, or you can't take it in the home. But in the hospitals are very easily available. The cost of one vial is less than is about $50, $50 to $60. That 5,000. No, not. It's about 4,000 rupees. 4,000 rupees. So the whole cost will cost about 20,000 rupees. Compared to a single vial produced in US from Gilead is about 60,000 rupees. So it's about 1/10 or 1/15 the cost in India. So that's why it's being used.
70 rupees is approximately $1. So you can do the
$70. So it's about 40.
Yeah,
it's about $40. Yeah.
We need to take a couple of questions. One question is about the time period that a patient is still infectious after he or she gets the disease.
It's important also that regarding Mukesh Prasad, so if the patient has COVID and it is believed that he can transmit the virus for up to 14 days after the development of symptoms, maximum 14 days. Usually it's 10 days, but beyond 14 days, even if he's having some viral particles in him, he doesn't transmit the virus because it gets very, very low attenuation. We, of course, can also check this by what we do is when we do the RT-PCR, we do actually what is called the cycle threshold, that amount of virus. If it is more than 25, that means the chance of transmission is very low. So in short, transmission can occur up to 15 days maximum. Beyond 15 days, it's very rare.
Yeah. Thank you again. And we have one last question about the mutations of the virus. Talks about what about the mutated version? I think Samar Gupta from MIT is asking about what about mutated version of this virus? Would
Yeah.
there be a need to develop new vaccines for the mutated versions in a hurry for giving to everyone?
Amar, actually, yeah, this is again a question that people are looking at very carefully. And what is fortunate is this virus has undergone thousands of mutations. In fact, thousands of mutations, because the RNA virus, each time it replicates, some mutation occurs. But what is very, very fortunate about it that these mutations, to some extent, may have increased the virulence of the virus, as we know the recent UK study. But these mutations have not changed the immunogenicity of this virus. It has not affected the immunogenicity, which means the same vaccines, the same antibodies are going to be effective against this virus. The only worry for us in future will come that if this virus is going to have a mutation in its immunogenicity, then we have to start thinking of new vaccines. But otherwise, till that time, we should not worry about it. And in general, if you look historically at coronaviruses, I mean, this is just one of the coronaviruses. If you look historically at coronaviruses, it is very rare to have mutation in the immunogenicity of the virus. The virus itself undergoes mutation, but not in the immunogenicity, and that's good news for us.
Again,
Paul asked whether aerosols as analogous to cigarette smoke. Of course, it's not as fully moving as cigarette smoke. It's much less because it's heavier than cigarette smoke. Cigarette smoke travels a long distance because it's much lighter.
Okay. Thank you very much, Dr. Nagesh Reddy, again for this enlightening talk, and I'm sure the audience enjoyed this. So again, it's almost 11:30 in the night for you, and we really appreciate your talking to us. And I think these are all you answered almost all the questions, so we won't be really following up with questions on that. And let me see, unless Paul or Ron, you have any other issues that we will bring this to a close. And
Dr. Reddy, on behalf of the Washington Academy of Sciences, I really want to thank you for this very informative talk. I mean, providing us a different perspective in a different part of the world, that's really is very helpful to the clinicians here in US as well. Thank you very much.
Yeah, again, thank you very much again for the talk. And you might have some parting advice to the people in US. Otherwise,
so my advice would be mask yourself and take the vaccine, please.
Okay, thank you.
Wise words.